Abortion has long been one of the most controversial and hotly debated topics in the United States. Although it is an incredibly safe procedure, with the risk of death associated with childbirth being approximately 14 times higher than that with abortion, anti-choice advocates continue to push for harsher regulations. In this piece, our goal is to give an overview of the history of abortion in the United States, explain the political motivations that affect reproductive policy decisions, explore how restrictions on reproductive rights disproportionately impact marginalized groups, delve into the most recent challenges to abortion rights in 2021, and suggest strategies and resources that can be implemented to support reproductive autonomy. For most of American history, abortion was legal until quickening, which is defined by the first time a pregnant person feels the fetus kick. This normally takes place between around 4 or 5 months of pregnancy, which is slightly longer than the first trimester cutoff set by Roe v. Wade. During this time, abortion was a safe process widely practiced by midwives and female healers with the use of herbal remedies. However, beginning in 1821, the first anti-abortion laws were passed in the form of poison control measures, which sought to limit the herbal and chemical substances used in the procedure. Nevertheless, the practice continued throughout most of the 19th century as states continued to pass harsher abortion restrictions. By 1910, abortion was illegal in every state except Kentucky, except when necessary to save the pregnant person's life. Amidst the increasing abortion restrictions throughout the 1800s, the Comstock Act was passed in 1873, which banned birth control and chemical abortion-inducing substances. There are many reasons for the increasing restrictions on reproductive rights at the time, but a resistance to the growing women's rights movement, religious fervor amidst the Second Great Awakening, and racist and anti-immigrant sentiments all played a part. First-wave feminism was burgeoning, and though its main goal was to achieve women's suffrage, it also fought for broader advancements for women in reshaping their roles in the home through voluntary motherhood. Furthermore, the eugenics movement and broader anxieties about increased Catholic immigration led to the push for American-born, white Protestant women to be forced to have more children and remain confined to the traditional childbearing role. At the time, the American Medical Association also fought hard to restrict abortion in an effort to assert dominance of their, quote, real physicians over female midwives who practiced abortion, many of whom were black. Unsurprisingly, illegal abortions continued to take place until the passage of Roe v. Wade in 1973. Thousands of people per year were treated for health complications due to botched, unsanitary, or self-induced abortions, and as many as 5,000 people died from them each year in the decades leading up to the ruling. Others were left infertile or with chronic illness and pain from the procedure. However, dedicated clinicians risked imprisonment, fines, and loss of medical licenses to continue to provide safe abortions to pregnant people in need. In Chicago, a group called the Abortion Counseling Service of the Chicago Women's Liberation Union created an underground feminist abortion service in 1969. The group, whose codename was Jane, provided safe, inexpensive, and supportive illegal abortions. Over a 4-year period, the group provided more than 11,000 first and second trimester abortions with a safety record comparable to that of today's legal medical facilities. The Comstock Act remained the federal standard until the Supreme Court ruling in Griswold v. Connecticut in 1965 guaranteed that married women in every state have the right to access birth control. It also established the precedent that the Constitution guarantees a right to privacy when individuals make decisions about intimate personal matters such as childbearing. In 1972, the ruling in Eisenstadt v. Baird guaranteed the same right for unmarried individuals. These rulings set the stage for perhaps the most notable victory in securing reproductive rights for Americans, the ruling on Roe v. Wade on January 22, 1973. In this ruling, the Supreme Court invalidated a Texas law prohibiting abortion unless to save the life of the pregnant person on the grounds that the constitutional right to privacy guaranteed by the 14th Amendment encompasses an individual's decision whether or not to terminate their pregnancy. The ruling also established the trimester framework, wherein states were not allowed to restrict abortion in the first trimester. During the second trimester, the state could regulate but not outlaw abortions in the interest of the pregnant person's health. After the second trimester, the fetus became viable, and the state could regulate or outlaw abortions in the interest of the potential life when necessary to preserve the life or health of the pregnant parent. The decision prompted swift backlash from conservative Americans. Just 3 years later, in 1976, the Hyde Amendment was passed, which prohibited the use of federal funds for abortion care. This restriction on federal Medicaid funding was upheld by the Supreme Court in Harris v. McRae in 1980. Since its passing, the Hyde Amendment and its progeny have expanded in scope and currently also limit federal funding of abortion services for federal employees, people in the military and Peace Corps, American Indian and Alaskan Native people who use the Indian Health Service, and people in federal prisons and immigration detention facilities. Under Hyde, federal Medicaid funding currently covers abortion only in cases of rape, incest, or when the pregnant person's life is endangered by an illness, injury, or physical disorder. Additionally, 33 states currently ban the use of state Medicaid funds for abortion as well. In 2017, over half of reproductive-age people on Medicaid, which is 7.9 million people, lived in states that restrict abortion coverage. Aside from funding, another obstacle to obtaining abortions for minors are parental consent laws. As of 2020, parental involvement of some kind in a minor's decision to access abortion is required in 37 states. However, in Bellotti v. Baird in 1979, the Supreme Court ruled that although states may require minors to obtain parental consent for an abortion, they must also have the opportunity to approach a court for authorization to have an abortion without first seeking the consent of their parents, and that these alternative proceedings must be confidential and expeditious. This right was upheld with the decision in Hodgson v. Minnesota in 1990. However, in City of Akron v. Akron Center for Reproductive Health in 1983, the Supreme Court ruled that the state could not require minors under 15 to obtain parental or judicial consent for an abortion, among other abortion protections. These included that states could not impose a 24-hour waiting period after the signing of the consent form, or require that all second trimester abortions be performed in a hospital. The Supreme Court's pattern of favoring abortion protection since Roe v. Wade began to shift in 1989 with the ruling on Webster v. Reproductive Health Services. The case was a challenge to a Missouri law that prevented the use of public facilities for all but life-saving abortions, required physicians to perform tests to determine fetal viability after 20 weeks of gestation, and imposed other restrictions. Frank Sussman argued on behalf of Reproductive Health Services.
Remains today, as it was in the days of Roe, 17 times safer than childbirth, 100 times safer than appendectomy, a safe procedure, minor surgery. I suggest that there can be no ordered liberty for women without control over their education, their employment, their health, their childbearing, and their personal aspirations. There does in fact exist a deeply rooted tradition that the government steer clear of decisions affecting the bedroom, childbearing, and the doctor-patient relationship as it pertains to these concerns.
Nevertheless, the Supreme Court upheld these anti-choice provisions, opening the door to further restriction on abortion rights at the state level. 3 years later, in Planned Parenthood v. Casey, the court upheld the constitutional protection for abortion, but introduced a new test for evaluating restrictive abortion laws. Under the undue burden test, state regulations are allowed so long as they do not place a, quote, substantial obstacle in the path of a woman seeking an abortion of a non-viable fetus. Catherine Colbert argued the case on behalf of Planned Parenthood.
Well, Bruce, the court took away a fundamental constitutional right from women. They established a new standard and permitted the states, gave the green light to states to enact restrictions which will jeopardize women's lives and health. But the court didn't go as far as they could have gone. So in that respect, we were pleased.
The ambiguity of the undue burden test has allowed many restrictions to pass court scrutiny. The next set of challenges occurred with respect to partial birth abortion, a non-medical term used by anti-choice activists to describe the medical procedure sometimes used in second trimester abortions, in which the fetus is removed intact from the patient's body. A Nebraska law prohibiting these procedures was struck down in Stenberg v. Carhart in 2000 because it didn't include a maternal health exception. However, this didn't stop the Partial Birth Abortion Ban Act of 2003 being passed by Congress and signed into law by George W. Bush. The law was challenged in 2007 in Gonzalez v. Carhart, and this time the statute was upheld due to the court's two new conservative appointees, John Roberts and Samuel Alito, overruling the Stenberg v. Carhart decision. Another group of abortion restrictions are known as gag rules. The first of these restrictions was the Helms Amendment, passed in 1973, which bars the use of U.S. foreign aid funds to support abortion care. In 1984, Ronald Reagan instituted the Mexico City policy, which became known as the Global Gag Rule. Under this policy, non-governmental organizations that want to continue receiving any U.S. family planning funding under Title X of the Federal Public Health Service Act must agree to stop providing abortion-related services or even advocating for the expansion of abortion access, using any source of their funding. Despite the harm these rules caused to non-American women seeking reproductive options, they were upheld in the Supreme Court in Rust v. Sullivan in 1991, and even expanded by the Trump administration in 2017 to apply to all U.S. global health assistance. Furthermore, in March 2019, the Trump administration enacted a domestic gag rule, which prohibits any U.S. clinics receiving Title X family planning funds from referring their patients for abortion health care. To no one's surprise, these increasingly stringent restrictions on abortion have had the most negative impacts on the most vulnerable. Notably, those who are Black and/or poor have suffered the most because they experience higher rates of unintended pregnancy, which result in higher rates of abortion. Although the pathways by which disparities in pregnancy and abortion rates occur are not completely clear, topics that have been studied include differences in neighborhood-level resources and opportunities, access to quality family planning care, mistrust of healthcare providers and contraceptive technologies, perceived infertility, and pregnancy attitudes. Rates of unintended pregnancy are highest among Blacks, Hispanics, and women with lower socioeconomic status. By race and ethnicity, 70% of all pregnancies among Black women and 57% among Hispanic women were unintended, compared to 42% among white women. With respect to income, 64% of pregnancies among women with an income of less than 100% of the federal poverty level were unintended, but only 37% of pregnancies were unintended among women with an income of more than 200% of the federal poverty level. Currently, about 1/3 of all abortions are obtained by white women, and 37% are obtained by Black women. Latinas comprise 22% of the women who have abortions, and the rest are obtained by Asians, Pacific Islanders, Native Americans, and women of mixed race. With respect to socioeconomic status, women with incomes less than 100% of the federal poverty level have an abortion rate of 52 abortions per 1,000 reproductive age women, compared with a rate of 9 per 1,000 among those with incomes greater than 200% of the federal poverty level. With respect to access, lack of insurance coverage for contraception and family planning care is a significant barrier, as it is estimated that more than half of U.S. women of reproductive age are in need of publicly funded family planning care, and only 40% of these women actually receive these services. Quality care is another factor, as non-white patients have been found to be less likely to rate their family planning visits positively. One survey study found that approximately 2/3 of Black women reported having experienced race-based discrimination when receiving family planning care. A recent analysis of a nationally representative survey indicated that skepticism about the motivation of family planning providers is widespread. 42% of Blacks and 51% of Hispanics surveyed believed that the government promotes birth control to limit minorities, compared to only 25% of whites. This skepticism is understandable due to the well-documented history of eugenics in the United States, which has resulted in the involuntary sterilization of more than 60,000 disproportionately Black and Hispanic people in 32 states in the 20th century. As recently as 1997 to 2010, involuntary sterilizations were performed on approximately 1,400 women in California prisons. Though these concerns are not unfounded, they can nonetheless prevent those who have or are at risk of unwanted pregnancy from receiving the care they need. 3 potential avenues for addressing these disparities in reproductive care include prevention of unintended pregnancy, access to quality abortion care and prenatal care, and economic supports for women who continue their unintended pregnancies to term. Although these approaches are likely to have some effect, they do not address the issues of structural poverty, racism, and lack of opportunity that underlie the disparities in contraceptive use and unintended pregnancy. Differences in neighborhood environments, discrimination in healthcare and other settings, and stratified educational and employment opportunities all reflect social and economic realities in the United States that are not addressed by these incremental approaches. As the mean charge for a non-hospital abortion at 10 weeks gestation is $543, and the mean charge for a non-hospital abortion at 20 weeks is $1,562, there are substantial financial barriers to access, particularly among low SES populations. Funding restrictions such as the Hyde Amendment and gag rules prevent those who are poor, who are more likely to be racialized individuals due to centuries of structural inequality and discrimination, from accessing these fundamental services. Because federal Medicaid funds cannot be used on abortion services, Black and Latina women are once again disproportionately affected due to the fact that 29% of Black women and 25% of Hispanic women are Medicaid recipients, compared to 15% of white women. A study in California, in which state Medicaid funding is available, further supports the importance of the availability of public funding on access to abortion. Women who reported difficulties obtaining Medicaid coverage experienced 4 times greater odds of having an abortion in the second trimester compared with those who did not experience barriers to this coverage, which puts them at increased risk of potential complications. Additionally, the burden on these at-risk women can be even higher depending on where they happen to live. Currently, 87% of all counties in the United States do not have an abortion provider, and 35% of women of reproductive age live in these counties. 6 states also have only a single abortion clinic. Because of this, some are forced to travel hundreds of miles across state lines, which once again targets poor women who may not have reliable transportation or cannot afford to take time off work unexpectedly, especially when mandatory waiting periods necessitate multiple trips or an overnight stay. In addition to disparities in unwanted pregnancy and abortion, people of color and low SES individuals experience higher instances of negative health outcomes across the board, with lower life expectancy, higher rates of HIV diagnoses, and higher instances of maternal and infant mortality. Black women and American Indian or Alaska Native women are 3.3 and 2.5 times more likely to die from pregnancy-related causes than white women, respectively. Approximately 60% of pregnancy-related deaths are preventable, so many of these deaths can be attributed to structural factors which prevent marginalized individuals from accessing prenatal care and/or receiving adequate treatment from the medical system. Access to abortion and family planning services is crucial to reducing maternal mortality across the board. When the United States legalized abortion in 1973, pregnancy-related deaths and hospitalizations due to complications of unsafe abortions reduced significantly. The number of abortion-related deaths fell from 40 deaths per 1 million live births in 1970 to 8 deaths per 1 million in 1976. After 1975, mortality due to legally induced abortion fell from 3 deaths per 100,000 abortions in 1975 to about 1 death per 100,000 abortions in 1976. However, despite the clear role that abortion plays in improving health and life outcomes for those experiencing unwanted pregnancy, we have only scratched the surface of the pushback that abortion rights have faced in the United States. Those who seek abortions, and even those who are seen entering a Planned Parenthood building to access non-abortion services, which comprise 97% of their care, face routine harassment from anti-abortion extremists. Though the Freedom of Access to Clinic Entrances Act of 1994 prohibits intentional property damage and the use of force or threat of force or physical obstruction to injure, intimidate, or interfere with someone entering a health facility, and the Supreme Court upheld a 15-foot buffer zone around clinic doorways, driveways, and parking lot entrances in Schenck v. Pro-Choice Network of Western New York in 1997, enforcement of these protections remains inconsistent. More than half of all clinics that provide abortion care still report experiencing threats and intimidation against doctors and staff, and volunteers must often step in to protect and support those walking into abortion clinics. Additionally, targeted regulations of abortion providers, known as trap laws, single out abortion providers and facilities by mandating burdensome and medically unnecessary requirements that are more stringent than requirements for other medical procedures of similar risk. These restrictions include facility requirements, such as hallway width requirements, or restrictions on providers, such as mandating admitting privileges at the nearest hospital. According to the Guttmacher Institute, as of 2020, 26 states have trap laws or policies in place. These laws do nothing to improve health outcomes and are simply tools used to shut down abortion providers who cannot comply. Now, legislatures in some states are seeking to ban abortion after only 6 weeks, describing their proposals as heartbeat bills. However, heartbeat is a deceptive descriptor. The American College of Obstetricians and Gynecologists has shown that at 6 weeks, the heart is yet to even form. What is heard instead is the electrical activity within a group of cells that will form the heart. No other nation in the world has heartbeat laws, yet this strategic language and marketing, similar to that used in the partial birth abortion debate, is a deliberate attempt to misrepresent abortion processes in order to garner support for the anti-choice movement. Crisis pregnancy centers also present themselves as health clinics offering pregnancy option services, but operate to dissuade individuals from seeking abortion care. They often provide inaccurate medical information, asserting false links between abortion and breast cancer, infertility, mental illness, and other misinformation.
Everything that's like a crisis pregnancy center, those things that are like pregnant, scared,
Right.
need help, all those things like only exist to scare people out of obtaining abortions and to provide misinformation on abortions, right? So they're like, oh, abortion's going to affect your fertility. You're not going to be able to breastfeed, or you're not going to be able to have another kid if you get rid of this one. Or, like Jesus will hate you personally for having an abortion, because they're all religious ran institutions funded by the state. And it's like all that money, that's taxpayer money going to this instead of going to actually support people's healthcare choices. You know what I mean? So that sucks. Makes it like CPCs legitimately scared thousands and like probably more, like hundreds of thousands of people away from obtaining abortions like across the US, because they exist everywhere.
Nevertheless, in the 2018 case of National Institute of Family and Life Advocates v. Becerra, the Supreme Court ruled that a California law regulating fake pregnancy clinics violated the First Amendment. The FDA has contributed to restricting abortion access through its imposed restrictions on the distribution of mifepristone, the primary drug used in most medication abortions. When the drug was approved in 2000, under pressure from the anti-abortion movement, the FDA blocked easy access using their Risk Evaluation and Mitigation Strategy, known as REMS. Under the REMS program, mifepristone must be dispensed in person at a clinic, medical office, or hospital under the supervision of a healthcare provider registered with the drug manufacturer. In addition, 18 states also currently require the prescribing clinician to be physically present when prescribing the abortion pill. 33 states require the clinician prescribing the abortion pill to be a physician, rather than another advanced practice clinician like a nurse practitioner or physician's assistant. Neither of these requirements have been shown to improve abortion safety or health outcomes. These restrictions, combined with the FDA's REMS program, have made telemedicine abortion, in which a provider can see a patient online and prescribe the medications for a first trimester abortion to be taken at home, very difficult to implement, which is a substantial barrier amidst the COVID-19 pandemic. As of 2020, 18 states have exclusively banned the use of telemedicine to provide medication abortion, despite the evidence that the service is safe and effective and has a high degree of patient satisfaction. Other strategies to limit abortion access include bans on abortion at arbitrary gestational ages, parental consent laws, waiting periods, and mandatory ultrasounds. Currently, 12 states also have trigger laws on the books that would completely ban abortion in the event that Roe v. Wade is overturned, and another 14 states are likely to ban abortion at some points shortly afterwards. In total, state legislatures have enacted 1,327 restrictions in the 48 years since Roe v. Wade was decided, including 580 restrictions enacted since 2011. The year 2021 is already a defining one in abortion rights history. The 97 abortion restrictions enacted through July already surpassed the count from 2011, previously the worst year on record, when 89 restrictions were enacted. The maternal mortality rate in the United States grew by 136% in the years between 1990 and 2013, largely in part due to these restrictions. Among these are the Texas and Mississippi laws which challenge Roe v. Wade to an unprecedented extent. The Texas law, known as Senate Bill or SB 8, functionally bans all abortions in Texas after 6 weeks, which make up approximately 85% of abortions because many don't even know they are pregnant at that point.
So what SB 8 is a 6-week abortion ban. So it bans all abortions over 6 weeks, and it creates this bounty law, part of the law, which allows private citizens to enforce it, to receive up to like a $10,000 bounty for reporting people who help others obtain an abortion outside of that 6-week time frame. So it's not going after the person who had the abortion, it's going out after anyone who helps them. So this law is really being, the way they created it is really smart, right? Because it's going to target like clinic workers, people who work at abortion funds, people who just talk about abortion, any people who are supportive of abortion. So it's like really honing in on that abortion stigma, right? Which is like the most effective tool for preventing abortions.
There were 7 million women of reproductive age in Texas as of 2019, and if most or all legal abortion care in the state were shut down, the average one-way driving distance to an abortion clinic would increase from 17 miles to 247 miles, more than 14 times the distance. After Texas's law went into effect, Republican lawmakers in at least half a dozen states said they would consider introducing similar bills, with the goal of enacting the abortion crackdown they've sought for years. Ohio is even considering a similar law which uses the same citizen enforcement method to target all abortions, even those before 6 weeks.
The total abortion ban is similar to SB 8 in Texas, but Ohio had to one up, obviously, and ours is a outright ban. There is no even 6-week window that they have in Texas. So yeah, things are bleak.
The Mississippi law that will be reviewed by the court makes most abortions illegal after 15 weeks of pregnancy, about 2 months earlier than Roe and later decisions allow. The law was enacted in 2018 by the Republican-dominated Mississippi legislature, but never went into effect because of an immediate legal challenge that led to a federal appellate court blocking its enforcement. If the law passed in 2018 were in practice, abortion providers who violated it could have their medical license suspended or revoked. The Mississippi law's supporters have made it clear that their intention with this case is to overturn Roe v. Wade, which seems likely due to the 3 new conservative Supreme Court justices appointed under the Trump administration. While these recent developments may appear bleak for those who support the right to choose, there are things that can be done to fight back against these attacks. In contrast to the trigger laws, which would immediately outlaw abortion in the event that Roe is overturned, 15 states and the District of Columbia have laws to protect abortion rights without Roe. So fighting for these protections in your state, if they don't already exist, is a good place to start. Advocates are now pushing for the Women's Health Protection Act, which would prohibit a range of abortion restrictions, including pre-viability bans, state mandates of unnecessary procedures and inaccurate counseling, barriers to telemedicine abortion, trap laws, and forcing extra in-person visits to a doctor. Furthermore, the Equal Access to Abortion Coverage and Health Insurance, known as the EACH Act, was introduced in 2015, and it aims to ensure the coverage of abortion for any person, regardless of how much they earn or the type of insurance they have. The All Above All campaign also unites organizations and individuals to lift the bans on public insurance coverage for abortions. Access can also be increased by expanding abortion training for clinicians. Currently, only 12% of medical schools teach first trimester abortion as a routine aspect of gynecology. A 2019 national survey of the American College of Obstetricians and Gynecology Fellows and Junior Fellows found that although 72% reported having a patient in the previous year who needed or wanted an abortion, only 24% provided this care. To address this shortcoming, pro-choice advocates are fighting for opt-out training for medical student, resident, and advanced practice clinician education, in which abortion training is the standard, but those with religious and moral objections can opt out of participation. More broadly, repealing state-level abortion restrictions, such as parental consent mandates, ultrasound requirements, waiting periods, funding bans, and limitations on the type of clinicians allowed to practice abortion is crucial to securing abortion access. In response to the COVID pandemic, removing restrictions on the incredibly safe practice of medication abortion and expanding telemedicine abortion is imperative. Moreover, securing universal access to contraception and funding comprehensive sex education for all K-12 students is crucial for preventing the unintended pregnancies which cause people to resort to abortion in the first place. It is clear that abortion is a crucial public health tool necessary for ensuring the life and health outcomes of childbearing individuals. In the roughly 100 years when abortion was illegal in the United States, women suffered and died from botched abortions. It is estimated that before 1973, approximately 800,000 U.S. women resorted to illegal abortion each year, with as many as 5,000 women dying every year in the decades leading up to the ruling. Currently, around the world, approximately 25 million resort to unsafe abortions each year, and complications from these procedures account for as many as 15% of all maternal deaths, approximately 44,000 annually. In 2020, Dr. Diana Green Foster published the results of a 10-year study on the impact abortion and being denied abortion has on women. The Turnaway Study, 10 years, 1,000 women, and the consequences of having or being denied abortion, provides definitive evidence that abortion access strongly enhances women's health and well-being, whereas denying abortion results in physical and economic harm. However, as important as the right to abortion is, supporting someone's decision to carry a pregnancy to term is equally important. Major steps need to be taken not only to secure equitable access to prenatal care, but also to correct the dramatic economic inequalities that cause many to feel that they cannot afford to raise a child, even if they would like to. Historically, restrictions on abortion have been shown not to decrease abortion rates, but to increase the number of unsafe abortions and cause disproportionate harm to the most vulnerable. Even in the most restrictive states, wealthy, privileged individuals will always be able to travel to get abortions if they want them, but the people who have the least time and resources to care for an unwanted child are left without the choice.
That's really what we're trying to get across, is that abortion is incredibly important and we need access to abortion, and also it's the first part of them stripping away our bodily autonomy. I don't know how deep into policy you are, but literally the rise of the Christian right was built off the back of abortion. Abortion has always been used as a political pawn. They started in the late 70s and 80s passing bills on the local level to get "In God We Trust" plaques on public schools. And now we have outright abortion bans. The same right-wing evangelical organizing has ramped up over the past few decades. And they're not going to stop at just taking away abortion access. They're coming for gay marriage next. Casey was a bedrock of abortion access. Casey, the SCOTUS decision, and also the bedrock for most of the marriage equality decision. So we have to stop this now. Yes, because everyone deserves abortion access, and also because we are sliding into a fascist government at light speed.
If those who claim to care about the life of someone's unborn child actually cared, they would be advocating for the policies that have been proven to reduce abortion, such as increased access to sex education and effective contraception, and those that would allow the child to grow up in a stable and healthy environment. However, the staunchest anti-abortion advocates are often some of the biggest opponents of universal health care and social safety nets. Restrictions on abortion and reproductive rights have and will always be about a group of mostly white men making decisions that will mostly impact those who are already marginalized on the basis of gender, race, and class. It's about asserting dominance in an effort to cling to the patriarchal social order without considering the real impacts that these decisions have on real people. Most of the people making these decisions to restrict access to reproductive care will never know the fear of being forced into bearing a child that you know you're not ready to take care of, or the helplessness that comes with being denied basic bodily autonomy over such a life-altering process. Nevertheless, there are currently resources available to help those who struggle to afford expensive reproductive care and need assistance with accessing abortion services, and activists and progressive policymakers will continue to fight for these basic human rights.